Hello, good evening, and welcome to the 10th session of Mastering Anatomy, Abdomen. Now, say before we proceed with today's session, there are few mails which I received. Now, and these are the questions. So I thought that let's settle those questions first, right? Because this would be in benefit of everyone. One question was that this rectus abdominis, how can it come in contact with this fascia transversalis? Won't transverse abdominis be coming into the picture in between? See, if it is like a bird's view, right? So what really happens is that 1, 2, 3 on both the sides, external oblique, internal oblique, and transverse abdominis, right? These are paired structures, so they are on both the sides. External oblique, internal oblique, and transverse abdominis. Then what happens that all of them, they merge in the form of that aponeurosis, right? That aponeurosis. This aponeurosis, it that splits, right? And there comes, here is the transverse abdominis. So that's how it comes in contact with this fascia transversalis, because over here the fascia, it would be all the way like this, right? Though this is not as per the correct dimension, but you got the idea that these structures, these muscles, they are laterally situated, and this rectus abdominis, it is in the center, right? So that is the first question. Yeah, I'm much better, much better. Though even today also there was some minor pain, and said trying to manage, and it is like one because of that dexamethasone, still the blood sugar is spiking like anything, so that leads to some complications. But anyway, today it is a much better. Okay, the second question, that was like, this is lesser sac, greater sac, and will they be communicating? Well, what I thought is that, see, let's draw the entire figure to make things completely clean, right? So we know at least this much part, that what is foregut, right? That's what we talked about. We know what is greater omentum, correct? We talked about lesser omentum, that is good, right? These things are known to you. Then we said that there is like epiploic foramen, which was that free margin. Still, even if there is any doubt, not to worry, as you'll be watching all the peritoneal reflections today, right? And then, as I said, the CT scan, right? You'll be watching the CT scans, things will be still clear. And then what I have done is, after completion of our today's topic, all the CT scan images, right? They are in duplicate. So on one, I'll be writing that, okay, this is aorta, this is superior vena cava, this, that, right? I'll write everything. And then rest of the images, right, the duplicate images, we won't be writing anything, so they are for your practice, right? So that's how we have planned out. And this is like, say, epiploic foramen. Then we talked about mesocolon, that is the transverse mesocolon, right? Mesentery and the lesser sac, right? So transverse mesocolon, then mesentery. Mesentery will be discussed in at length today, and the lesser omentum. So what I thought is, let's draw a figure right from the scratch, right? Sometimes it happens that when we see the real images, but if we draw one image which is like a schematic image, but actually it will cover all the concepts, right? So let's draw it. Say that's abdomen, right? So this would be thorax, and here is the abdomen. Let's draw it like this. Okay, right? So that is thorax, and just below it is abdomen. And this is our symbolic liver, right? And over here, there would be stomach, right? Then we have that transverse colon, and we know that third part of duodenum, right? That would be posterior. And then this triangular part would be pancreas, right? And then there are intestinal loops. Now let's draw, and this is his stomach, this one is the liver, right? So first thing first, what we draw is the lesser sac, right? How lesser sac develops? All the way from the liver, right? It comes, right? Stomach, correct? Then behind the stomach, right? That is where it is forming that greater omentum, right? And this entire sac is just behind the stomach, right? All those reflections, correct? All those reflections, and over here onto the liver, because liver has pressed the wall, so it won't be going all the way like this. No, no, it will be, it would be, and it would be going like this, because here it will be forming all those ligaments of the liver, but that is when it will come. So this portion, this is lesser sac. This entire blue thing is lesser sac, right? Now what about rest of the reflection? As we said that as we remove the anterior abdominal wall, right, with the anterior abdominal wall there is association of that peritoneum, right? So once that is removed, so over here liver really pushed it, so that's why, right, we found this gap, and that would be a sort of ligament. So right now we are not touching it, okay, sorry, right? And then from liver, right, again it goes like this, and it is forming that greater omentum, right? And it goes like that transverse mesocolon, right? And obviously from here it would be going for all these mesenteries, and in case of males this is like a complete closed sac, right? The sac is complete. In case of females, yes, it will be communicating with that femoral end, right? That's what we talked about previously. So when we say the, so if we really mark this, all these things, so here there would be that epiploic foramen, right? So that's where it is, the epiploic foramen. So where exactly we see the greater sac, right? So greater sac is, we can just say it like greater sac, right? It is the entire jejunal cavity, right, which is inside peritoneum but outside lesser sac. Here it is. So actually it is this epiploic foramen which is communicating between greater sac and the lesser sac. Got the idea, right? So this would be the greater sac, and it is this epiploic foramen which is over here. Yes, from ventral mesogastrium. That's right. So here is transverse mesocolon, right? That one would be greater omentum, and this one would be the lesser omentum. All right, and this is mesentery of small intestine. Just a minute, I need to drink water. Just a minute. Yeah. So now we start with say these images, right? So we start with duodenum. Now, duodenum is as such the most difficult organ to see because it is covered by so many structures, right? Here, this is stomach, right? That is stomach. And in order to see this thing, we need to cut down the lower ribs because then and then we can really see the stomach, because otherwise we won't be able to see the stomach so much, right? So here we have removed the lower ribs. This structure, yes, you know that it is right, very easily identifiable, and that is gallbladder, right? So far it is all good. Okay, bit zoomed part. Here even the left lobe of liver has been removed, right? Left lobe liver, right? That has been removed. This is gallbladder, that's stomach. But over here, at least now we can see the things very clearly. See over here, right? It is going like this, and that's the duodenum, right? So here is, it is the duodenum. Now duodenum divided into say 1, 2, 3, 4 parts, right? And we said that in case of foregut, it is the stomach plus D1, right? The first part of duodenum, that is the part of this foregut. And obviously we have removed the greater omentum, etc., so that at least we can see these structures properly. Watch for this part. This is mesentery, right? This is mesentery, right? That is the mesentery. So if we really want to see full duodenum, we have to remove this mesentery also. So that's what we'll do. I'll just write mesentery. And this is the full exposure of duodenum, right? So that is duodenum, classically seen as that C loop, right? The complete C loop. In between this C loop, right? So here there would be pancreas, correct? That is the pancreas. Now pancreas is like a coma-shaped structure. Coma-shaped structure. And this process, this is what is called as the uncinate process. Not to worry, but this uncinate process, it is as such important, right? Pancreas, as you know, it's beta cells of islet of Langerhans, right? Islet of Langerhans. They are responsible for insulin secretion, right? Very vital. Okay. This is much better, right? So you can see that this one is the gallbladder, and we have got this one. This is the D1. That's the D2, right? The second part of duodenum. And it is over here, right, where we'll see that from above that CBD, common bile duct, and which will be meeting the pancreatic duct, and it will be opening over here, right? That is what is called as the ampulla of Vater, right? Ampulla of Vater, right? That will open. And over here after duodenum there would be jejunum. So that's why this turn, right, that is called as the duodeno-jejunal flexure. It is green because of bile, because bile is green, right? So that's why it is green. This is duodeno-jejunal flexure, right? Yeah, but pancreas is as such very attractive because its location is so precise. And once when we'll be discussing the pancreas, right, एकदम अच्छे से पहचान में आ जाएगा. Okay, so this is D3 and that one is D4. Okay, now we'll see why is D1 black. Because D1 is quite near to it, is just as such it is normally not black, but because this is post-mortem, right? After death, that gallbladder, some bile must have leaked, and that's what it has, say, decolored the D1. Otherwise, so it is not such, and it is quite clean. Okay. So let's see over here, right? This is again a conceptual thing, right? This is again for our concept. And this one thing will make entire GIT very easy. This is stomach, correct? That's stomach. So this one would be foregut. Then that's the duodenum. So duodenum is as such midgut, but to be very specific, what we'll do is we'll just write it over here, D2, D3, D4. So that's why let's write D1 over here, right? So it makes things much easier. Then these are jejuno-ilial loops. So over here, it is like collectively we write jejuno-ilial, right? So it includes both of them. So it is midgut, right? Still, midgut is not over, right? Over here, this is, there would be, we'll see it. This is cecum, right? Then there would be appendix. Then this is ascending colon, right? Ascending colon, all the way till this point where the blue thing is shown. So it means, say, ascending colon and the transverse colon, and in transverse colon, two-third of the transverse colon, they all are midgut. That's the reason even the blood supply would change for the last part of this transverse colon, right? And then and then over here, transverse colon, let's say the last one-third, and the descending colon, they all are part of hindgut, right? Hindgut. In descending colon, though it is not shown over here, but we'll also add the sigmoid colon. All these things we are going to see today in the form of the real dissection. Right? Flexure means turn. That's right. Flexure means turn. That's right. This curve, the turn, is called as flexure. Right? So this is also hindgut. Now we'll quickly go through few images, right? So that concept becomes more clear. Let's start with this, right? Over here, say this is foregut, this entire is midgut, and this one is hindgut. So colors match, right? And here starts the rotation, right? So all set. Here is our tube, right? So this is foregut, midgut, and the hindgut. Flexes, it bends, further bends, right? And then it starts looping. But the loop itself is such that it is this portion, which will be forming ascending colon. It loops till this point, so it is just a loop, but then this ascending colon, it comes forward, right? So now the whole rotation is in 3D. So this ascending colon comes forward. So here it is, right? See this structure, that would be the duodenum. It goes back, and this colon, now it comes in front, right? And it continues. Then after this process, so it is as per the final state. This is the final state. That's how it is reached. Here, important thing is only one, that this duodenum, it goes back, and this transverse colon and the ascending colon, right, they come forward. Bus, right? Okay. Now for all these images, right? Now we'll see all these structures actually. So there might be some overlap what we learned yesterday in that also, right? So first thing first, the lesser omentum. Lesser omentum, always remember this is the liver, right? This is the liver. We have removed some portion of liver, so what? It is there, right? And there is the stomach. So in between, it is always lesser omentum, right? Lesser omentum. If it is lesser omentum, the next structure which we would like to see, and we would see that, see, this is the lesser omentum, right? That's the lesser omentum, this one. So this is here is a free border, right? I'll just now remove it. That's the free border. It means this is that natural entry into the lesser sac. So it is epiploic foramen, correct? Epiploic foramen, also called as foramen of Winslow, right? Winslow, foramen of Winslow. So that is the entry into the lesser sac. This lesser omentum would be till what point? It would be till proximal duodenum, right? It is till proximal duodenum. Why do we say that? That it would be till proximal duodenum? Because this lesser omentum was formed by ventral mesogastrium, and we know that it is only in foregut where there is ventral mesogastrium, right? Ventral meso-G is only in case of foregut. After midgut and the hindgut, there is no ventral, there is only dorsal. That's why there are only those single mesentery is there. This entire game of greater omentum, lesser omentum, etc., that is only in the foregut. So here it is. That's the epiploic foramen, right, which is displayed bit more properly, and that's the foramen, right? So this one would be lesser omentum, correct? And obviously that's the stomach. Right? Further, yes, remember D1, right? D1, that was part of foregut. Now D2, D3 and D4, they are part of midgut. So if we really draw it like this, the shape is this 2, 3 and 4. This is the shape, right? This is D1, D2, D3 and D4. When we'll be studying the duodenum, at that point, all the parts D1, D2, D3, D4 and their entire all relations, right, they will be discussed. But it is at D4, right, there is a ligament. Ligament means peritoneal reflection, right? Thickened peritoneal fold. And it is this part, right? This. Right? If I change the color, that's the part. This is the part. This is, you can just say it is like a peritoneal fold, and it is called as the suspensory ligament. Name itself is telling, right? Its function is support, and it is called as suspensory ligament of Treats. T-R-I-E-T-Z. Sit, right? That. So that is suspensory ligament for duodenum. Right? These are jejuno-ilial folds. So jejuno-ilial folds, right? Jejunum and ilium. This is like about 6 meters, right? These fold, length of these folds, that is about 6 meters. But when it comes to mesentery, right? The mesentery, this mesentery is 30 times more. It's 30x than its attachment. So its attachment is like this from the distal part, that is the D3 to where the cecum is there, right? But the reflection that it is like this. So it is like a fan, right? You must have seen the fan, because when you open it, oh, it is that big, right? That big. But when the fan is closed, so it is just this much thick. But when it opens, all the way it becomes big, right? Right now, don't worry about the treats. It is just a peritoneal fold, thickened peritoneal fold at D4, right? D4 for the support. All those structures, right? Say duodenum itself is a massive topic, so it will come in any case. So that's what I said over here. This is suspensory ligament with supports, right? Just it is a supportive ligament. All these ligaments, right? Actually, if you'll see, they don't support much, but they are there, whatever the support which they provide. Hindgut parts we said, no? Hindgut parts, Asha, we didn't talk about. No, we said it over here. Just a minute. Yeah, here it is. See, hindgut parts, right? Transverse colon. This is all red portion is hindgut. Sigmoid colon, right? That is all hindgut. Okay. So back to our point. So these are jejuno-ilial folds, right? They are thrown into multiple folds to increase the surface area. So here it starts all the way, right? That connection, right? See, this is right now it is not seen very cleanly, but it is this area which is called as the cecum, right? So at the base of the cecum over here, the mesentery is attached, the attachment of mesentery, and then up it goes at the end of D3, right? At the end of D3. So this is the base of the attachment, and then the entire mesentery, it is thrown into multiple folds, and that's how it is connected, right? We'll see it, but let's see. That's what I want. If you pick up one jejunal loop, right, and if you pull it, you'll find, okay, loop is this much, but when you pull it, oh, there is so much of mesentery. That's the mesentery which we are talking about. Mesentery. You'll see several images now, right, in next 1 minute. Several, because they are thrown into folds. See, here it is. Now these mesenteries, right, say that's the loop, but when you lift it, oh, there is so much of mesentery, right? That's what really happens in every loop. Now these mesentery, right? These mesentery, they are having blood vessels. They are called as the arcade of blood vessels. So what we are watching over here is this. It is called as the arcade of blood vessels. Now there is a difference between jejunum and ilium, right? So when we see in case of jejunum, right, and we see in case of jejunum, this is the type of arcade you watch, right? Seedha, simple, right, like this. This is one arcade. Right? Can you see? Right, quite simple, straight vessels they are seen. Okay, that is in case of jejunum. See how they differ when we are watching further. This is one part is different to other or same. Which part we are talking about? I'm not getting the question, right? Just let me know what you really want to ask. Which part is different to other? Okay. Meantime, this is right. That was proximal, right, jejunum, and as you go distally, right, distal jejunum or ilium, see the arcade. Now these are called as the multiple arcades. That's how the blood vessels, they change. Multiple arcades. These are the multiple arcades, and they keep on increasing as you go distally, right? So as you start from jejunum, they are straight, and then as you go towards ilium, they become multiple arcades. So you can watch it like, say, they are like this, one, two, and then from here, the vessels, they are going out, correct? And let me erase this so that in your record, you actually look at the proper image. Yes, right? So compare this with this, right? No doubt about it. Yeah. These are the mucosal folds. These are the mucosal folds. They are thrown into folds, and remember another difference. When you say jejunum, so in jejunum there are more folds, and these folds, they will decrease as compared, means when you'll go towards ilium, right? So in case of ilium, less folds, right? So these are the folds, mucosal folds. All these are mucosal folds. Now if you go into still microscopic level, you will find, right, see, they are like this, all this, right? They are called as villi. They are called as villi. The function of villi is to increase surface area. So these villi, they are like small, minute projections, and they increase surface area, right? They increase the surface area. It looks like caterpillar. And you got its emoji also. Okay. Now, say all these are jejuno-ilial loops, right? Jejuno-ilial loops. And then finally, these loops, they end. This caterpillar ends over here, right? This is like tail of caterpillar. And this is ilium, right? Now this lands, this ilium, it lands into this bigger area, and this is called as the cecum. This is called as cecum, right? So it's like this, and this is ilium. Over here there would be appendix, and that's why this is called as the IC junction, iliocecal junction. So let's see. Here it is, much better, right? So we have got the cecum, and this one is ilium, and actually this worm-like, right? This worm-like structure, it is worm-like, so we'll call it vermiform appendix. Vermiform appendix. Again, this is a vestigial organ. Vestigial means slowly and gradually this organ is losing its existence because it is not needed, right? And over here there would be ileocecal valve. Now this ileocecal valve is, we'll see it in more detail, but this, which view is this? And Digital India. Okay, which view is this means? This is like wall removed, right? And one by one we are removing the structure and we are watching anterior view. Right? We are, all these are anterior view. Just anterior abdominal wall has been removed, and that's how the things look like. Yesterday I got a mail. Someone said very interestingly that it's like, say, beauty is just skin deep. Yeah, actually it is like that, right? Whatever you watch, that is just the external beauty. Otherwise, deep inside, it is all like this, like worms, as you said, Digital India. Okay. But well, there is a sense of beauty even in this also. True. And here is vermiform appendix. See how it looks like, right? Vermiform appendix. I tell you, the most interesting part is the brain, right? When we'll study the brain, means you'll be fascinated that, see, over here the structures, they are so big, and yes, it makes sense, but then when it comes to brain, right, it is so good that how one section will be talking to other section, how systematically the whole process will, I mean, vision, auditory, thought process, all those memories, right, emotions, how systematically everything is arranged, and how every part, say, influences other part. Very interesting, right? We'll study. Okay. Now, say this is the ilium, right? That one is cecum, and this one is appendix. And yes, vermiform appendix. Okay. Now, when we cut, right? See how it looks like. This is this portion, right? That is ileocecal valve. So actually it is the ilium which penetrates, right, into the cecum. So here is that ileocecal valve. Now this valve is not at all very efficient, right? And these are the mucosal folds over here. These are the mucosal folds, because that's how this valve acts. But it is not very efficient, because when we do the barium enema, you remember barium enema, as the enema was given, as the barium was entered from the anal canal, it used to pass through that descending colon to transverse colon to ascending colon, and then through cecum again it was percolating into the small intestine. That's because this particular valve is not very effective, right? So that's the ileocecal valve, not very effective, right? Not very effective. And as a proof, we just write barium enema, right? The rest of the story you know very well. Now, if you see deep into this opening over here, that is where that chota sa, that appendicular, that is the appendicular opening, right? Appendix opens at that point. Okay. See the view, right? So here, that's the ascending colon, that's the transverse one, right? That's the transverse colon. And this transverse colon then they dips deep, right? Over here, for the clarity, we have removed jejunum and ilium, right? They have been removed. Now see, that's about few important points about colon. Colon is actually a big pipe. So that's why it is divided into smaller sections, and they are called as the hostrations. They are called as the hostrations. So it is like this. Actually, when we draw colon, we draw it like this, right? So these are all big. They are called as the hostrations. The importance is because it is a big tube, right? So that's why it is necessary to divide it into smaller components, so that that bolus, that food, that material which has been sent by the ilium, that can really travel like this, right, by the peristaltic action. And in between there are small bands, right? These are the small bands. Actually there are three, right? So these are what is called as the tinea coli, right? Tinea vesicle. These. So as such, they are three in number, right? 1, 2, and third one will be on the opposite side. Okay, here is, see, that's the hostration. Right? I'll just write H, that would be sufficient. And all these are, say, mucosal folds, right? These are the mucosal folds which we see. Mucosal folds. Right? And these hostrations, as we said, they divide the whole thing into multiple parts, right? So it becomes easier. Now, when the ascending colon travels up, then it takes turn, right? So this area, right, this turn, as very rightly said by you, that flexure means turn, right? So this is hepatic flexure. Why hepatic? Nothing, right? It is like that my house is near that point where the cow sits. This is just a landmark, right? This is just a landmark that on the right side, right? So someone cannot give the address like this. So this is a very proper address, that where will this colon take turn? Near the liver. That makes sense. So this is hepatic flexure. So on the opposite side, there would be some other name, right? Yes, there would be. Whosoever will be near, right, they will be getting its importance. Right? So here, when we pull this, we have pulled the hepatic flexure, right, bit mercilessly, and when we pull it, we see that okay, here is the liver and that greenish gallbladder, right? That the gallbladder. Okay. Now, in order to see this thing, you have to just remember that what's this structure? This one. Well, that was greater omentum. So we lifted the greater omentum, right? Greater omentum was like this, right? And then there was the transverse colon. So greater omentum has been lifted, right? And then we see that yes, this is the transverse colon, right? The transverse mesocolon. Yeah. So that is the transverse colon, and this one is transverse mesocolon. Still better, you want to see? Here it is, right? Here is seen with much better clarity. Now this transverse mesocolon, right? This transverse mesocolon. It will cover the peritoneum. Yes, it will cover the pancreas because pancreas was posterior most. So here we say it covers pancreas. To be specific, pancreatic head. And yes, this one is greater omentum, because once we lift the greater omentum, then and then we'll see that yes, it is this transverse colon. Right? In case if there is any confusion, think it like this, that this was the greater omentum, right? And over here is the transverse, and that's how, and when this is, and this is what, that is transverse mesocolon. Transverse mesocolon, right? This one. So we are talking about this. When we say transverse mesocolon, we are talking about this. The anterior part, this part, right? Yes, that is greater omentum, but that has been lifted up, right? Now, this is a very nicely taken picture. What it is? Again, we have put the omentum back. So that's stomach, right? And between the stomach and the colon, right? So if we just try to palpate, right? So here is the transverse colon. That's the transverse colon, which we are feeling through greater momentum, right? Through greater momentum. Good one. And see, this in between thickened fold, that's the thickened peritoneal fold. And this is actually gastrocolic ligament, right? So this one is stomach. Over here, that's the colon which we felt, right? Transverse colon. And in between, so this is gastrocolic ligament. So that's how they look like, right? It is actually, when you feel it, you find that yes, this is thickened. So that is gastrocolic ligament. Okay. Now this is transverse colon. This transverse colon, it dips deep. It dips much deeper. And before that, and then it takes the turn and goes for the descending colon. And this area is called as the splenic flexure, right? That's the address given to this turn. So splenic flexure, because spleen is near, right? So easy. And here is deep, right? Again, when we pull this splenic flexure, we see that yes, deep over there, that is the spleen. All these things will help you a lot when you'll be watching the CT scan, because in CT scan it is like a section, right? It is like a section. So here it goes down, and that's the entire thing, that is the descending colon, right? So that's the descending colon. Simple. Let's look further. Yeah. Now this descending colon, as it goes down, right? This is quite short, right? This descending colon, right? It is short. And then as it goes down, it will end up in this portion. And this is called as the sigmoid colon. Sigmoid colon. Yes, sigmoid colon, that is also part of hindgut, right? And this sigmoid colon, it takes the central position and it goes deep into the pelvis, right? Yes, it has to be. Some part of the duodenum and the pancreas is under transverse mesocolon, definitely. Because in fact, duodenum to bichara is posterior and pancreas is, so it is retroperitoneal. So yes, they will be behind the transverse mesocolon, sure. Now here it is. So when you, this is mesocolon, right? This is mesocolon. Colon, mesentery of colon. So that is mesocolon, right? And because this is the sigmoid colon, so that's why we'll call it a sigmoid mesocolon, right? Mesentery, which is covering the sigmoid colon. So that is the sigmoid. And then from here, it is taking that central position. So when we say, see here, see, it goes deep. Now it passes down into the peritoneum and then it becomes narrower, right? If you see, this is becoming narrow, right? And it is entering into the pelvis. So but just at that point, that mesocolon ends, right? It is now mesocolon ends, because this will be opening into rectum, and rectum, there is no covering, there is no peritoneal covering, right? Over here we just pull it and we see that deep, the structure which we see is the rectum. Now from this point onwards, say entire thing is into the pelvic cavity. Till this point we were watching the abdominal cavity. But let's finish the process. So what we do is, we take two sections, right? One we take the coronal section and one would be the sagittal section. So when we cut it, we'll be getting a very proper orientation that what exactly, how exactly they just end up. So this is the section, right? Section or cut, which we'll be watching. So when it is like this, obviously this would be the sag section, sagittal section, and we'll also have one more, right? A section like this, right? Transverse. So here it is. So if we just cut it like a coronal section, right? A coronal section. So if this is the head, like this, right? These are the two ears. So as it goes like this, same way over here, right? If we take a section, see these are head of the femurs, right? These are the femur head. And that's the abdominal cavity, right? And over here, from here, everything is into pelvic cavity. This is rectum. That's the rectum, right? So in case of this is sigmoid colon, where there is mesentery and then it narrows down and it opens into rectum, right? Over here, this is all iliac crest, right? Iliac crest. And so this is all, say, hip joint. Okay. Just for the reference, if you really cut it, this is how, this is the cut, right? And we watch the structure over here. True. That's the rectum, right? With no coverings, with no peritoneal covering, right? And this one is sigmoid. Just a zoomed version so that you see it properly. This is good. So that was the coronal section. I think I wrote sag. If I have written sag, it is incorrect. No, it is fine. I have written coronal. This is okay. Sagittal I wrote above. Yeah. So now this is the sagittal section, right? Sagittal section. So here is, if this is the head, like this, right? So that's how it is cut. So it is dividing the entire body into two parts, and we are watching it. So when we watch it from the side, this is rectum. This is rectum. Now this image you just register in your mind, because it will be used again and again, as it will be carrying few important points, and those important points are: one, the rectum, right? This rectum, it takes turn, and it goes like this. This rectum, it goes like this. Now I tell you one very, very classical thing, and this is so true. Say in washrooms there is one Indian style, right? And then there is one European style, right? Mostly it is like this. Now, why they say that Indian style of washrooms, they are far better and it will not lead to constipation? It is because of this angle. It is because of this angle, right? When person squats and sits, so there would be proper pressure on the rectum for the emptying. In European style, when it is like person is sitting on the chair, there won't be such proper pressure, right? That may lead to constipations, right? And this is so true. So then what should be the solution? Now actually it is said that solution is very simple, that when it is okay to use this European style, but the idea is that the knees should be above, right? Knees should be above. So if a footrest is used, so that knees, they are above, Bus. That serves the purpose. More when we'll be talking about the rectum and we'll be understanding it, because it is having those sphincters. Internal sphincter, right? That is, there is internal sphincter and the external sphincter. They are called as sphincter. Sphincter, right? Sphincter means they are like valves, right? So this internal sphincter is involuntary. I for I, involuntary. But this external sphincter is voluntary. So again, the process of passage of stools, passage of feces, right? It is again a very systematic process, right? How these muscles they take part of it. And over here there would be a muscle called levator ani, right? Levator ani. Ani is anal canal, levator means it elevates, and this is the muscle which will be playing a major role because it actually pulls and it takes the rectum into the correct direction so that rectum can be emptied, right? And this levator ani will be taking a very major part in the formation of pelvic diaphragm. So we saw pelvic diagram. It is pelvic diaphragm. Now it is okay, right? Okay. Just in front of rectum, this is urinary bladder, right? That is the urinary bladder. If I draw the shape of the urinary bladder, the bladder shape would be something like this, right? A big topic. And do you see? Zoom. Over here, a structure which is like this one, right? Now try to appreciate it, right? Now you see that structure, that is seminal vesicle. So this is a male, this is seminal vesicle. Over here, that's the seminal vesicle. And when this is bladder, just over here, that's the prostate. Because see, in male, it is the common urethra which will be responsible for both the secretions, right? Semen as well as the urine, right? So this one is prostate. Where the prostate is over here, this one at the neck of the bladder, just remember, neck of the bladder you get prostate, and here is the prostate, right? Now in case if you really find that things are getting mixed up, everything is looking so similar, don't worry, right? This is just you, I'm getting, say, making you comfortable that these are the structures which you'll watch. In any case, all of them, they are the major topics. We'll be covering all of them. Unzoom, right? Same things. So you can see seminal vesicle, right? Urinary bladder and the prostate. I'll just write seminal vesicle. That's the prostate. This is the urinary bladder. Now, in case of female, right? Say bladder would be there, but none of the other structures, right? No prostate, no seminal vesicle, and in fact there would be the uterus. So this uterus would be like this. It would be sitting over the urinary bladder. So that's where the uterus would be present. Uterus in females, right? So that's the urinary bladder. Rest of the structures you know, right? Okay, this is rectum, right? And that's the muscle, right? That's the muscle which is there. This one is levator ani. And see how the rectum takes the sharp posterior turn, right? Sharp posterior turn, and before it ends up in anal canal. This is anterior view, right? This is anterior view. And that's the rectum, which is fully distended, right? This is fully distended. And here is the pelvic diaphragm. Again, we'll be using this image, right? This is the pelvic diaphragm. We'll be using this image when we'll be studying the pelvis, right? Because at times it becomes very confusing that where exactly the structures are arranged. That's why, though we are supposed to peritoneum, so it has finished way back, right, above, but we are understanding this so that you become comfortable that this is how the structures are arranged, and step by step we'll keep on adding more structures. So over here on both the sides, these are the fatty connective tissues, right? Fatty connective tissues. Similarly on the opposite side. Now just few images and then we are about to hit CT scan, right? So over here, now see, you'll be able to identify this is, right? See, such a powerful, nice muscle, that is levator ani, right? We saw it so many times. Now it is, and in fact, this is the only important muscle which is present over here, right? And just remember that it takes, rectus takes turn like this. This is important, right? And over here, do remember that there is anococcygeal ligament. So between anal canal and that coccyx, yes, that's it, right? Coccyx, which was the last end of the spine, vertebral column. Okay, so few images, we just go through them fast. Ligamentum teres, no, we won't be talking about it, right? Because we have not yet touched it. Quadrate lobe, don't worry much. Gallbladder, that's okay, right? Porta hepatis, yes, we have talked about, right? Right lobe of liver, inferior vena cava, bare area, portal vein, right? Say, just see this. Lesser omentum, we know the lesser omentum, and rest of the structures we have not actually touched. So take it this way. Lesser omentum is between stomach and the liver, bus, and that's the right free margin of lesser omentum. That's the only thing which we have currently seen. This is good. Duodenojejunal flexure, and then that's the site, right? That's how it is arranged. Say this is the mesentery with folds, and this is this portion, right? This one. Then I'll remove it, right? But this is what I was talking, that's where the mesentery is attached, and then over here that mesentery is thrown into several folds, right? So attached area is just this much for rest of the mesentery, right? That is like a fan, it is folded and it is connected to the respective loops. This is easy, right? Ascending colon, mesentery, that is ilium. Meso appendix makes sense, right? Because this is the mesentery of vermiform appendix, and that's the cecum which we saw. This figure is good, easy. Here also, right? So this is head of pancreas, body of pancreas, tail of pancreas, and actually this one, right? This one is uncinate process, uncinate process, right? A coma shaped. And this is the left end of transverse colon, right? Transverse mesocolon, duodenum, all good. C loop of duodenum, that is where this sits. This is easy. Abdominal aorta, common iliac artery, right? Regarding this left ureter, etc., not to worry. Ureter is again a separate topic. We'll be learning it. This divides into external iliac and internal iliac, And these are the areas. That's the area where there will be sigmoid colon, right? Just keep in mind. Diaphragm. Regarding this falciform ligament, not to worry about, none. They will come when we'll be talking about the liver itself. So no worries. Yeah, this should be good. Liver is fine, right? There is like, say, those kidneys, they are retroperitoneal, right? And this is a aorta. Watch for this aorta, right? And then there will be pancreas. I think, in fact, we understood it in much better way. This is making things bit complex. I think we go for the CT scan. You'll get much better idea, much better. Even this we understood. Okay. And I'm not talking about any of the rectovesical pouch or all those things right now, right? As such, it is easy. It is between rectum and the urinary bladder. So that is the pouch which is between both these organs, and that is called as a rectovesical pouch. But no worries. Liver, right? Lesser omentum, stomach, pancreas, transverse mesocolon, duodenum, transverse colon, mesentery, small intestine, greater omentum, rectum, urinary bladder, prostate, right? Umbilicus. This much we know. Regarding all these pouches, say urinary bladder and the uterus. So now we'll call this pouch as vesico-uterine pouch, right? Vesicle means urinary bladder, bladder between the bladder and the uterus. So it is vesico-uterine pouch, right? And there is behind, there is a space, and that is between rectum and the uterus. So obviously recto-uterine, recto-vaginal pouch, anything, because this lower portion is vagina, this above is a uterus. So this portion, this space which is over here, it would be recto-uterine or the rectovaginal pouch, right? Rest is all self-explanatory. Again, all of the topics, they will be coming individually. Now starts the CT scan. You'll find this thing pretty easy, right? Initially it looks so intimidating, but then as you go systematically, you'll find that it is not that complicated. First thing first, right? Just watch for this portion, this, that is aorta. So big, so prominent, right? And perfectly round. That is aorta. This one is liver. So this one would be the right lobe of liver, right lobe of liver. Now, how are we really watching? As we said that in CT scan, you just do one thing. Patient is lying, you are standing on the leg side, and then as the section is taken, now you are watching. Got the idea? That right? This is the gantry. Patient is sleeping over here, and the digital section is taken, and you are watching from the leg side. From leg side. So when you are watching him from the leg side, so it means his right side. This would be his right side, and this would be his left side, right? This would be the top, so that means it is his anterior, and this side is the posterior, right? We are taking where the section is taken, that is always indicated by that figure. So the section is at this level, right? Over here, it is telling that even the diaphragm, so this is black portion, that is lungs, right? So this is left lung and the right lung. You might ask a question that lungs, they are looking so black. Yes, they are looking black because of the presence of air. But when you are supposed to do the CT scan of lungs, so at that point you will be changing the intensity of the beam so that you get the structure of the lungs more properly. Right now our focus is towards the abdomen. In abdomen you have to increase the exposure so the beam would be powerful. So lungs, they are seen black because through and through all the rays will be passing through the lungs because they are so strong. So there won't be differentiation of the tissues of the lungs because they are not our prime focus at this point of time. So on right side we have got the right lobe of liver, right? And this one, I'll change, I'll put it back. This is right lobe, of liver, and this is left lobe. Left lobe. Now there is something like quadrate lobe, etc., but will not complicate the matter right now. Right? This is caudate lobe, but watch for this portion. Right? See, they look so similar. Right? They look so similar, but when I remove this, you'll find yes. We can see that this artery is very properly defined, but this is bit ill defined, but still it is quite a circle, right? Even in next image, it is seen. See, so properly. This is so nicely seen, and big one. Its caliber is bigger than the aorta, right? I'll just remove this so that so over here, this is IVC, inferior vena cava, right? That is inferior vena cava. Okay, so you now know right lobe, left lobe of liver, you know inferior vena cava, and yeah, by the way, say these are the rectus abdominis, exactly in the front, right? So that's rectus abdominis, this and this, right? So in between there would be that linea alba, right? That center line. Okay, from aorta, at this point in time there is celiac trunk comes out, right? Celiac trunk, and then one goes towards that splenic artery, etc., but these are the sections. So at this section, right, see one, right, that is celiac trunk, this is the reason I have put all these images, right? At the end there are images and they will be unmarked, so you can utilize those images for your practice, correct? Okay, the higher on the left hand side, this area, this is what, where there is so much of space. Well, that is simply stomach. No other structure can actually come over here, so that is stomach. Then on the outer side, see there is some space, and it is going like this, right? So this is splenic flexure, right? That is splenic flexure. Splenic flexure, it is of colon. And then see the consistency of liver, the appearance of liver, and the structure which is purely on the left hand side. Well, it is spleen. So good, correct? So spleen, the stomach, you can identify aorta easily, spleen, stomach, splenic flexure, celiac trunk you can identify. You can identify rectus abdominis properly, right lobe, left lobe of liver properly, inferior vena cava properly. What else you would really want? This is absolutely fantastic, right? Black portion upper to left lobe, black portion, I mean, this one, this is, right? This is air. This is air in stomach. Right? Now you'll find things much easier. So this is stomach, right? That's stomach. This one is splenic flexure. And this black portion over there, because there is some air into the colon also. So this is the splenic flexure. Good. Over here, say it is seen quite nicely. This portion, this portion. Now I remove this. That one is diaphragm. Right? It is diaphragm. Now I'm not marking other structures, right? This is aorta. Right? That now you know that. So this is aorta. See, this is inferior vena cava. Right? But what we see very nicely, this one, that is hepatic portal, right? So this is hepatic portal vein. That is hepatic portal vein. we go for still a lower cut, right? This thing will generate the entire idea that how things are really going on. So over here, structures which we now know very well, this is aorta, this is inferior vena cava, right? Easy. And spleen, liver, everything fine, right? See over here, this one is spleen, right? So properly. And we are watching something. This is spleen, that's fine, but who is this, right? It is kidney, right? Obviously the left kidney. And as we'll see, this indicates that left kidney is at a higher level, right? So as we'll go down, we'll take one more section, we'll find, okay, right kidney would also start appearing, right? And anything else? Yes, one more interesting thing. From celiac trunk, there goes the splenic artery, right? So that is what we should see over here, right? Over here. Right now it is not seen very clearly, so we are not mentioning it. Otherwise, rest all of them, they are the colons, right? So this is stomach, and that's colon, right? Obviously it is on the splenic side. Okay, let's go more. See, things are becoming better and better. Now what we know aorta, we know IVC, right? There is formation of one structure over here, right? Whose consistency is bit different, and that is gallbladder. So if you know that this is the location of gallbladder, and if you find something white opacities in that, so you can make a guess that it could be the gallbladder stones, right? That's portal vein, right? That's portal vein. All these images you have to keep on watching again and again. As soon as, let's say, we finish liver, immediately you go to these images and then figure out that can you identify something more. Yes, you'll be coming across so many even other structures also, right? Okay, right now I'm just making you comfortable with bigger structures. So this is like jejunal loops, right? See, from aorta, something is going out. So prominent. Something is going out. So this section has been beautifully taken exactly at the level where this artery is emerging. No, they are all are almost of the same intensity, right? Because when the section is taken, when the slices are taken, to right, it is normally not changed. Almost the same level of exposure through and through the abdomen, right? Though it may look like different, but no, they are all same. Okay, here it is, right? Here it is. There is something which is coming out. Yes, it is a branch which is coming straight away out of aorta, and it is the superior mesenteric artery, right? More when we'll talk about the superior mesenteric artery, but do remember this is one of the important artery, right? And here it is. See the kidney, right? How nicely it is seen. Kidney, right? And it is a left kidney which we are watching, seen very clearly. And see, this is this one. Who is this? Pushed. That's the spleen, right? That's the spleen. That's the spleen. Fine. Let's go further. See, opposite side kidney has started appearing, right? So this is left kidney, and this one is right kidney. Correct? See the gallbladder, how nicely it is now seen. Gallbladder, so clearly. Correct? This anterior-most structure, anterior-most, right? It is transverse colon. And over here, this would be the descending colon. in between all those loops. Correct? Good. Right kidney, left kidney, and see, you can watch even the renal vessels. Fair enough? Right? And yes, that's aorta, this one is IVC, etc. See, we are now going quite deeper, right? Quite low. This is where you are watching, it is fully studded with all those jejunal loops, right? They are like jejunal loops. I want you to see this one. See this big muscle, it is a muscle. So at this level, if I really draw, it is this muscle we are talking about. It is this muscle, which will soon be accompanied by its partner, iliacus, right? So that is the psoas major. This is the psoas major. Right? So that's the psoas major. And here is, say, that rectus abdominis, right? And this one externally, this is external oblique, and inside, right, there is transversus abdominis, and here they will be forming that aponeurosis, and then that aponeurosis will be forming anterior and posterior rectus sheath, etc. Right? Over here, this is the aorta, this is IVC, all those are jejunal loops. The important is psoas major, right? That's the psoas major, both the sides. Almost at the end, this is psoas major, right? And here it is iliacus, right? And now you can identify that, okay, this is the hip bone, right? That is the hip bone. And this one is the iliac region. Still, the last image, right? What it is showing, this is urinary bladder, right? Urinary bladder. Where exactly the section? Watch it. It is almost absolutely in the pelvis, right? So that is urinary bladder. Then what would this be? That is the rectum, right? Then do you see small structures like right? They are ureters. They are ureter, right? Left and right. This one, yes, it is rectus abdominis, correct? Okay, now this is another section, right? Over here, this will give much better idea. So over here, there is thorax. I'll give you some very important point. This is what is called as the costodiaphragmatic recess or the costophrenic angle, right? So this is costodiaphragmatic recess. This means it is a space. So whenever there is pleural effusion, right, this space would be obliterated if there is any pleural effusion, right? Because what you are watching over here, that is nothing but diaphragm, right? So that is diaphragm. Now, so this one would be liver, right? And we see this prominent part, so this one would be gallbladder, correct? And the colons which we are watching immediately over there, so obviously it has to be transverse colon, correct? And below, these are all jejunal loops, right? Shape itself is telling that they are the jejunal loops, right? Over here, say, that's the level of section, so which is on the right hand side. So now on the right side we are cutting the kidney, so this is right kidney. Okay, right, that is right kidney. And classically, right, we just watch the rest of the bones, right? They are also seen. Let's move towards the midline and see what we get. The new structures, right? The newer structures. These are all muscles, right? Muscles like erector spinae, etc. So these are all muscles. You are on one side, so this one is like ascending colon. Right? That's the ascending colon. Rest, portal vein, hepatic artery, bile duct, they all are seen over here, which is called as the portal triad. But right now, not we are worrying about it. Yeah, this is okay, right? This would be the right kidney, and in kidney there is ureter, right? There would be ureter, artery, vein. All those things, they can be seen over here. So that is renal artery, vein, and the ureter. Complete section, right? So that's liver, right? See, almost it is in midsection, right? It is in midsection. So over here, this would be the transverse colon, and then we have got all those loops, duodenum, and liver we talked about. So now we are going towards the left hand side, right? You are watching this, right? That's how so over here, stomach is becoming more prominent. So stomach will be there, right? Then this would be the left kidney, because now we are going towards the left side, right? And then there will be renal artery, veins, etc. Still better, right? We are now almost pushed on the lateral side, right? So here, that's your left kidney. All these are descending loops, right? Just by look at it, you can say, right? These are the descending loops. Then on top of it, this is what we are watching this area. So this is spleen, right? Because it is extreme left side. So we see that as spleen, right? And over here, this one is, yes, you are right. This is a diaphragm, right? That's the diaphragm. And on top of it, there is heart, lungs, thorax, right? All those, right? Lungs, heart is here. That. So that's it for today. Now see, from this point onwards, I've kept all these images, right? All these images for practice. So right from here, all the images, and you have to just identify the major structures. You don't have to struggle for every small structure. Even if you identify these structures which we talked about, that is more than enough, right? So that's it for today, right? Thank you so much. And I think we'll have one more session on this abdominal cavity, right? I'll just look into it and I'll let you know, right? I'll save this and we'll put it into our shared folder. All right. So thank you so much, and we meet soon. Bye bye. I'm happy that you liked it.